Hello, today we're discussing atherosclerosis, risk factors, and emerging technologies. Overview and objectives. Atherosclerotic cardiovascular disease is the leading cause of morbidity and mortality worldwide. We're going to cover pathogenesis, risk factors, new research, therapeutic advances. In covering the risk factors, an important new finding is the CHIP, clonal hematopoiesis of indeterminate potential. We are all aware of the traditional risk factors: male gender, age, elevated cholesterol, hypertension, diabetes, family history. This is one of the emerging risk factors. It has to do with acquisition of somatic mutations in hematopoietic stem cells, causing expansion of mutant blood cell clones. This does not increase risk of overt blood cancer, increases cardiovascular risk. LDL is a primary causal factor in atherosclerosis. The lipid hypothesis proposes that elevated levels of cholesterol in the blood lead to the development of atherosclerosis, whereas CHIP is an age-related mutational process that alters hematopoiesis, and these mutated clones in T2, DNMT3A enhance inflammation, and the AM2 inflammasome exacerbates atherosclerotic clonal hematopoiesis, which is age-related. LDL mechanisms. LDL enters the intima, becomes oxidized, recruits monocytes, forms foam cells. High LDL is necessary and sufficient to induce experimental atherosclerosis. CHIP mechanisms produce hyperinflammatory macrophages and activate inflammasomes, AIM2 in particular, which worsens plaque development. LDL presence across the lifespan. Elevation occurs due to diet, genetics, and lifestyle. Universal exposure to LDL makes it a population-wide driver of atherosclerosis. CHIP prevalence increases steeply with aging, and it reshapes the age-related cardiovascular disease. Historical milestones in atherosclerosis pathology. They started in the late 1800s, and that's when atherosclerosis was named initially. Subsequently, the lipid hypothesis came about, and then the newer inflammation hypothesis thereafter. The inflammatory precedent was set by Rudolf Virchow. He was the first to see atherosclerosis not as a passive deposition, but as an active tissue reaction. He termed the condition endoarthritis chronica deformans. He noted the frequency with which the cells in a state of fatty degeneration are found in inflamed parts, and was directly linking inflammation to cellular transformation of foam cells. Virchow's view was sidelined for nearly a century because a simpler, reproducible lipid hypothesis provided clearer experimental causality. And NHCow demonstrated that feeding rabbits a high cholesterol diet caused elevated blood cholesterol followed by arterial atherogenosis. He was the first to describe characteristic lipid-laden macrophage, and he called it a cholesterol esterophagocytin. His findings countered the prevailing senescence hypothesis, that is, atherosclerosis as inevitable aging. The modern synthesis is a response to injury. This was pioneered by Russell Ross in 1976. This hypothesis established atherosclerosis as a complex biological reaction to endothelial injury, and endothelial injury or dysfunction caused platelet adherence, the release of mitogens, focal proliferation of smooth muscle cells in the intima. This was subsequently refined, and chronic vascular inflammation initiated by modified lipoproteins acting as a neoantigens. Initiation of the plaque formation begins with endothelial dysfunction from hypertension, smoking, increased permeability, and adhesion of molecular expression. LDL particles enter the intima, become oxidized. Oxidized LDL accumulation triggers immune responses. Monocytes migrate to the intima and form foam cells. Retained LDL and dying foam cells stimulate chronic inflammation. Macrophages and endothelial cells release cytokines, interleukin 1 beta, and tumor necrosis factor alpha, amplifying immune cell recruitment. Vascular smooth muscle cells migrate and proliferate and synthesize the fibrous cap. So atherosclerosis is an interconnected web. It contains modifiable, non-modifiable, and emerging factors as components of the web as shown in this infographic. The key cell type are macrophages or foam cells. They were largely seen as passive graveyards of lipids in the past, but now are found to be active drivers of atherogenesis and plaque instability. After ingesting oxidized LDL, they become foam cells, and their apoptosis, cell death, and failure of clearance directly contribute to expansion of the highly inflammatory prothrombotic necrotic core. The second key cell type is vascular smooth muscle cells. Pre-1990, uh, vascular smooth muscle cells in advanced plaque were thought to be beneficial. The modern view is that this is an overly simplistic view. Phenotype switching causes the vascular smooth muscle cells to lose their identity and adopt macrophage-like or fibroblast-like characteristics. Apoptosis and senescence of these cells within the cap are detrimental events that promote inflammation. Then plaque progresses and thrombotic complications ensue. Fatty streaks evolve to mature atherosclerotic plaques, that is fibrous cap with necrotic core. Inflammatory mediators like metallic metalloproteinases from activated macrophages degrade the collagen of the cap. A thin cap fibroatheroma ruptures, exposing underlying thrombogenic materials. Clinical manifestations are coronary artery disease such as a heart attack, cerebrovascular disease such as a stroke, peripheral artery disease such as limb loss. This infographic illustrates the entire sequence of plaque progression and thrombotic complications. Initially, the fatty streaks evolve into mature atherosclerotic plaques with a fibrous cap and necrotic core. They contain inflammation and foam cell death that enlarges the core, and then calcification occurs in advanced lesions. Inflammatory mediators like matrix metalloproteinases form activated macrophages that degrade the collagen of the fibrous cap. Then a thin cap fibroerythroma is formed that ruptures, exposing the underlying thrombogenic material. This leads to the clinical manifestations. Plaque instability, the vulnerable plaque. The nomenclature of the vulnerable plaque was adopted in 1989. Thin cap fibroathyroma is a precursor to rupture. The thin fibrous cap is typically less than 65 micrometers thick. Large necrotic core forms more than 30% of plaque volume. High inflammation with significant infiltration of macrophages, T cells, and low density of protective vascular smooth muscle cells is seen. Rupture occurs when inflammatory mediated proteolysis overwhelms the mechanical strength of the thin fibrous cap. Now there's a paradigm shift from lesion to disease burden. Pathology study shows that many and potentially most plaque ruptures are subclinical and heal spontaneously, contributing to vessel narrowing, but not acute events. Acute events are hypothesized to require plaque rupture, erosion to coincide with systemic thrombus promoting conditions. Management now mandates a greater focus on the overall atherosclerotic disease burden, magnitude and activity of the plaque. Systemic risk factors contribute to a thrombotic milieu. The old paradigm was a vulnerable plaque. The new paradigm is a vulnerable patient. Thank you for watching.